Good morning. This is Dr. Kanav Anand here. Welcome, Dr. Kanav Anand, for this interesting session for kids in kidney disease. Over to you, Doctor.
A very warm welcome to all of you who are here. I am Dr. Kanav Anand. I am a children's kidney specialist, a pediatric nephrologist at Sir Gangaram Hospital, Division of Pediatric Nephrology and Renal Transplantation, Institute of Child Health. And a warm welcome from our division as well. And I'm based at Delhi. So today I'll be talking about chronic kidney disease in children. Now, tracing CKD early enough. So basically what it means is to pick up, how can we pick up a chronic kidney disease in children early enough so that we have a good outcomes. In case we start a therapy early, we pick them up early. So definitely the chances of it going into a permanent renal failure, or you can say end stage renal disease, where you think about dialysis and transplant, that reduces down. So basically by picking them early, we can help children preventing going into end stage renal disease, and at the same time prevent the burden on the family in terms of the financial burden, what we are talking about, as well as the emotional burden of children who are having an end stage renal disease. So can I share my screen?
Yes.
Yes. So is the screen visible?
Yes.
Yeah, sure. So let us start the presentation. So tracing CKD early enough in children. Now, what is chronic kidney disease? It means a loss of kidney function, which is a long-standing and is gradually progressive. Usually, this loss of function is irreversible, in contrary to acute kidney injury, where majority of the children, the kidney function recovers back. Function less than 15% is called as end-stage renal disease. So in the early stages of chronic kidney disease, when the function loss is not significant enough, okay, if you pick them up early, you can initiate therapies early so that the progression to end-stage renal disease is slowed down and we can have good outcomes. So often, a lot of people pick, like if you talk in terms of the Indian scenario, most of the times, by the time the patient actually reaches the doctor, he has already entered end-stage renal disease and you can't do much for it. So if you talk about my practice, like 50% of the children with CKD would have already entered end-stage renal disease by the time they actually reach us. So what we will be focusing now will be how to pick up that rest 50% where we can basically pick up the problem earlier and prevent the progression. So remember, end-stage renal disease does not mean the end of life. It means it's the end of kidney function, which can be managed by dialysis or kidney transplantation. So how common is chronic kidney disease in children? The prevalence is less than 16 years of age is almost 1.5 to 3 per lakh children. And as I've already told you, up to 50% of the patient presenting with CKD to a doctor would have already entered end-stage renal disease. And this is global figures. What are the causes of chronic kidney disease in children? The first and foremost are the birth defects or the congenital anomalies with which the child is born with. Either it can be like small size kidneys, cysts in the kidney. So small size kidney just means that there's the number of glomeruli or the filter units in the kidney are much lesser. Either they have got spoiled off or they are by birth, they are less. And this can be easily picked up by the antenatal ultrasounds. So if a pregnant mother undergoes ultrasounds, and any of the ultrasound shows the kidneys is small for the age, definitely these are the children where you need to follow them up once the child is born. Okay, and remember, when more than 50% of the kidney function has gone, that is the time when the creatinine starts rising. So the first 50% of the loss of kidney function, the creatinine may not rise at all. So you need to actually pick them up early. You should have high index of suspicion. And these antenatal ultrasounds give you that index of suspicion that this child may be having some troubles in the future. Or we can have problem related to reflux nephropathy. Now, what does reflux nephropathy means? If you see in this slide, from the kidney, the urine gets formed, goes into the pelvis, goes into the ureters, enters the bladder, and it is out. So it's all a one-way system. So in case of reflux, the valve, which is basically causing the one-way flow, right from kidney into the bladder and out, that gets damaged. Because of which, whenever the bladder starts contracting, the urine starts going up into the kidney, and once it reaches the kidney, it can start damaging the kidney. So in utero, while the child is inside the mother's womb, even normal urine, or you can say the non-infected sterile urine, also can damage the kidney. But once the child is born, usually it's the infected urine, the urinary tract infections, where the infected urine goes up to the kidney and may damage the kidneys. So other reasons can be obstruction in the passage of the outflow tract of the urine. Means this is the kidney. So in the outflow tract, maybe you have a problem out here, which is also called as a pelvic-ureteric junction obstruction. So if this obstruction is significant, the urine will not be able to come down and hence causing a back pressure into the kidney, resulting in kidney damage. Or there may be obstruction at the level of the ureter to the bladder, that is called as VU junction obstruction. Or it can be an obstruction at the level of exit of the bladder or the bladder outlet, called as posterior valve, which causes outflow obstruction, which is usually seen in boys. So any obstruction in the outflow tract can also result in kidney damage. Now, this can be either in terms of a birth defect, or it can be maybe a kidney, you can say kidney stone, which gets stuck in the tract, resulting in increase in the swellings of the kidney and resulting in kidney damage. So this is the most common entity. But the other less common entities which can cause kidney damage on long-term basis is the glomerular diseases like focal segment glomerulosclerosis, hemolytic uremic syndromes. Now, kidney involvement as a result of diseases in the other parts of the body like SLE, systemic lupus erythematosus, hinoxal and purpura. So you have a disease entity in other parts of the body, including the kidney, where kidney manifestations may cause progression of the kidney damage. So these children require high index of suspicion just to keep checking whether the kidney damage is there or not there. In case it is there, you need to treat them off early. Then you have familial causes like Alport syndrome or cysts in the kidney, where in the initial phase of life, things may be perfect, no problems at all. But as the age progresses, the child may have some proteinuria, sorry, and slowly the kidney damage may progress and the creatinine may start rising up. Then diabetes and hypertension can also result in kidney damage, but usually seen in older children and adults. And you have miscellaneous causes like tumors in the kidney or damage of the kidney because of some kind of infections or toxins or drugs. Now, how can one recognize that the child has CKD? Most of the time, as we have told you, why does a child come very late to a doctor? Is because most of the time it is either asymptomatic or the symptoms of signs and symptoms very non-specific, where you will never think that these symptoms are because of kidney problem. Now, what are the common problems where you should have a high index of suspicion that my child may be having some kind of kidney disorder, and let me go to the doctor asking whether the child has some kidney troubles or not. One can be a nausea and vomiting, but remember it is persistent nausea and vomiting. You have given medicines for the child, maybe you had some diarrhea, some nausea, vomiting, you have given medicines. Diarrhea settled down or the fever settled down, but nausea, vomiting is not settling down at all. So a child with persistent nausea, vomiting, definitely you need to check the urea and creatinine because a high urea can also cause a similar. Extreme degree of tiredness, which is usually progressive. Loss of appetite, any swelling over the eyes or the ankles, which is again persistent. Froth in the urine or bubbling in the urine, which is persistent froth. Means the child passed urine, there's a lot of froth which you saw in the toilet. After half an hour, if you go, still the froth is persistent. This gives you a clue that the child may be having some kind of urinary protein loss. Persistent itching, again because of urea. Shortness of breath, the child keeps breathing very fast. Sometimes the doctor says it looks like the child may be having pneumonia, but when he does an X-ray, it's perfectly normal. Now, this is because of the acidosis. The kidney is not working well, there is acidosis, and this child is breathing very fast. So a lot of kids do come down to our OPD saying that I showed my doctor for a number of times. He told us there's cough, cold, there may be some kind of congestion. That's why the child is breathing fast. But after all the therapy, the child did not improve. And once the testings were done, definitely then the doctor told me, okay, this looks like a kidney problem. And that is the reason why the child is breathing so fast. Then other non-specific symptoms can be in terms of like passage of excess urine or less urine. So in case you are passing huge amount of urine, the volume of the urine is high, or the child is having increased frequency of urine. The child is passing urine around 10, 20 times a day, or less urine. Maybe he's just passing 2 to 3 times in a day. So both tells you that there is some trouble in the kidney. Then failure to thrive, a child not growing well, height and weight persistently it is on the lower side. The doctor did his evaluation, nothing came out very specifically. You start giving him all the multivitamin tonics, still it is not working. The child is not thriving well. Gives you a clue that the child may be having some kind of kidney trouble. Or bony pains, bony deformities, again, which is persistent. Normally, you may go to the doctor, doctor says it's rickets. He gives you vitamin D supplements, calcium supplements, the child is not improving. As even after supplement, the reports are going worse and worse. Again, tells you that there is some trouble with the kidney. And do not forget that child's BP needs to be checked. In case a small child's BP is on the higher side, that means the child is having hypertension. This tells you that there is some trouble with your kidney. That's why the BPs are on the higher side. Lot of children have never got their blood pressure checked because most of the parents feel that BP is a disease of adulthood, not because in children. Remember, in our OPDs, when the child comes, even for newborns, we check blood pressure because unless you screen, how do you know that the BP is high? Then simple lab tests like maybe urea, creatinine, calcium phosphate levels, blood count, checking for the hemoglobin, a simple urine analysis where you check for WBC in the urine or protein can help you in picking up kidney disease. So simple tests can also go a long way in picking up kidney disease early. Rarely you may require high-end testing like maybe ultrasounds and CT scans or a biopsies or maybe other tests like ECG and all for further workup. But most of the time, simple ultrasound, a urine routine, and just a urea creatinine can give you significant information about involvement of the kidney. So if you see this cartoon, so most of the time when the kidney damage occurs and the GFR starts falling down and the creatinine starts rising, this is the time when majority of the patients actually reach the doctor. But our aim is in the normal population, we need to screen the high risk children. Once screened, follow them up so that in the early damage times only, once the mild damage has occurred, you need to correct it off or put a full stop to that damage so that the progression to the stage of kidney failure does not occur because then the complication starts increasing. So that is the main aim of doing this presentation. Now, who are the children where we need to screen? Now, remember these 3, 4 slides which I'm going to show you is the slides which I actually show my pediatrician whom we go and teach, telling them that these are the children who need to be screened for CKD. Now, first and foremost are children with low birth weight or preterm children because they have a high risk of development of CKD. Children with antenatally detected kidney anomalies, where we have already discussed before. Children with history of acute kidney injury or maybe a mild renal failure which occurred in the past, which has actually become normal. Okay, but these children also need to be screened because in case kidney failure may have increased, but if the BP is persistent or the proteinuria is significant, the urine, you can say urine protein is significant, these children will progress to CKD in the near future. And then children who have history of recurrent urinary tract infections with an background evidence of reflux. Then children who are having those systemic diseases where kidney may get involved, like we discussed is henoch-Schönlein purpura or SLE. Now children who have outflow tract obstruction, which we have discussed in the form of a that cartoon that I showed you. Then if there is a family history of renal disease, like people who have family history of chronic kidney disease, family history of cystic kidney disease, again, they need to be screened. And children who have hypertension needs to be under the radar of a follow-up, whether this hypertension may cause long-term kidney damage if not managed well. Then children who are on painkiller medication, non-steroidal, you can say anti-inflammatory drugs, like for maybe they have joint involvement or some other problem for which the doctor is regularly giving them this anti-inflammatory drugs. So their painkillers, these children also needs to be screened for CKD. Then children with renal rickets, means you have got rickets, there was vitamin D, calcium supplements were given, and now again the child is slowly showing a progression of the rickets. So these children also need to be screened for a long-term CKD. So what are the early indicators of CKD? So one is unexplained failure to thrive, means if the child is not growing well. Anemia, maybe if there's a deficiency in the hemoglobin is on the lower side, anemia is there, and the doctor has already treated you with iron, multivitamin, B12, folic acid, everything is done. Still, the child's hemoglobin is not picking up. Again, that tells you a clue, gives you a clue that there is some problem with the kidney. Next is rickets, which you already discussed, and hypertension, which you already discussed. Thank you.